Okay, well, let's start. Welcome, everyone. On behalf of the SCTS, I see the Honorary Secretary, Doug is on, Doug West, and my co-chair, Rory Beattie, is also on. We want to facilitate this webinar after some discussion in the Thoracic Forum WhatsApp group. So just to say that the meeting will start with a presentation from Joel Dunning regarding Hasimur's 10-year data reports, which will affect everyday practice. Eric Lim will then review the previous Lancet paper. Babu will also be on, Nadu, who will discuss the current PSP, the priority setting partnership that's ongoing with the James Linden Alliance. There may be some opportunities for NIHR grants if we do go down the route of a trial. Ram is here as well, and we'll discuss the new thoracic surgery database with Dendrite. I've also asked Sasha to say a few words to comment on segmentectomy work from St. Bart's, and then we'll open it to the floor. And as we go along, can you please introduce yourself and let us know which unit you're from when you're asking a question. This webinar is going to be taped and may be edited for the CTSNet, and obviously will guide some further discussion with other senior members of staff who have sent apologies who can't make it today. Okay, so we're going to start off with Joel. Thank you for raising this issue within the forum, much to our surprise. And if you'd like to share your slides, we'll take it from there. Thank you.
Yeah. So yeah, thank you everyone for coming along. Thank you, Karen, for being so great and organising this at short notice, because this really is genuinely a massive bombshell. This is genuinely shaking the foundation of thoracic surgery, and this is massive. And here is the most important slide. This is Hisao Asimura. This is the first author of JCOG, one of the most senior surgeons in Japan, with the words, "The Lancet paper is misleading. We are sorry. Do not do segmentectomy as the radical resection for lung cancer, even if small and peripherally located." He wrote those words. They could not be clearer. He feels his 10-year results mean that we must now do lobectomy in preference to segmentectomy. And this is absolutely massive and practice changing. So I'm going to set the background of this for everybody. I may try and say controversial things. Feel free to shoot me down, and feel free to put comments in the chat as well while we're going, because certainly you can all see the chat and when we can get that going. But I think the really important thing is we as a community need to decide, what are we going to do? Are we going to change practice? What does it mean? And there were already loads of questions about this issue. So we'd like to answer this perhaps in this 1 hour and subsequent webinars. So let's move on. Segmentectomy or lobectomy. So prior to these two studies, there were actually more meta-analyses than studies. Everybody's super interested in this, but nobody was answering the question. It was kind of crazy that people kept meta-analyzing rather than actually doing. So we didn't know, when do you do a lobectomy, when do you do a wedge, and who gets what before these massive trials. So let's just talk first of all, who should just have a lobectomy? Well, the jury is not out on this. Basically, the studies would not even recruit someone above 20 millimeters. The jury is not out above 20 millimeters. So, everyone must have a lobectomy unless they've got such compromised lung function, you don't think that they can survive it. I put on there, just to be controversial, 18 millimeters clinically on a CT scan, may turn out on histology to be 21 millimeters or something like that. So I personally don't tend to apply the JCOG criteria if they're above about 18 or 19 millimeters, but more than 20 millimeters, don't do a segmentectomy for a standard patient. Who can have a wedge? Well, the teeny tinies. There's very good evidence of excellent and outstanding survival for the absolutely teeny tiny nodules and SEER data and many other showing that the very, very tiny nodules will have great outcome and very low incidence of N0. So we're really talking this middle of the bat, probably 1 to 2 centimeters, and that is what JCOG was designed to answer. So the JCOG study, it's really worthwhile having a look at their entry criteria because they're very strict. You've got to be suitable for both. So we're not talking about very impaired lung function, can't survive a lobectomy. We're talking about people that could have both. So they said as well, you must do systematic lymph node dissection for all these patients. They must have frozen section for these lymph nodes. If it's N1 on frozen section, you're going to go to a lobectomy. They were looking very carefully at their distance to the dissection margin. And if that was not looking really big, like 20 millimeters, they'd send it for frozen section to confirm it was negative. So they're doing a lot of things that we don't actually do, that a lot of us around the country wished we could do, but haven't. And so that's just really important to just remember. That was their entry criteria. They took photographs of all their resections as well. You know, they were very meticulous. Just remember as well, we can still do segmentectomies on metastases, on people not fit for lobectomy. The middle lobe's never going to get a segmentectomy. That would be stupid. If you suspect strongly there's N1 disease or you're proving it, of course you're not going to. And maybe if you can't get frozen section, you shouldn't be doing segmentectomy because of about a 1 in 7 to 1 in 10 chance it could be N1. So you know, those are things to just be thinking about. So who are we thinking about? Well, maybe it's between 10 and 18 to 20 that this fight's going on. So I'll just remind you on what the results were at 5 years. And this was Hisao Asimura, first author, presenting. This was kind of the weird bombshell that actually they were saying there was a 3% survival advantage. This was kind of shocking, and I'm sure Eric will tell you how actually it must not be correct. But they had a p-value of 0.0082. So the paper was telling you you'll actually save lives with a segmentectomy than compared to a lobectomy. And as we'll see later, that probably actually isn't correct. For me, this is the most important slide. If you take nothing else away, it's the lung function. The JCOG did not prove a lung function advantage in segmentectomy. Now, a lot of you will quote, oh, there was 3.5% better lung function in the segmentectomy group, but actually the minimum clinically important difference that they were looking for was 10%, and they did not achieve that. They got a p-value because it's such a huge study, but how many of us think that a 3% improvement in lung function, FEV1, FVC, means anything whatsoever to a patient? If I had a treatment that could improve my FEV1 by 3% to improve breathing, would we apply it? No, we wouldn't. So this was also a negative finding, not a positive finding. So we haven't got something in this trial that benefits the patients according to JCOG. Relapse-free survival was essentially equivalent. And then here was the other kicker. At the 5-year, there was double the local regional recurrence in the segmentectomy group to the lobectomy group. So 7% versus 3%. That's pretty big. That's double. And that's an important thing and very positive in the p-value, but also clinically relevant as well. So that was another finding. But they concluded if you're fit, then you might improve their survival by segmentectomy. And so that's what we all took away from it. Now, before we just go on to the bombshell mic drop slides that were given in China very recently, just what did the Nasser Al-Turki CALGB study say? Because that's obviously the other big player in the field. Remember, they randomized to lobectomy or sublow resection. About half of them were wedges as well as segments. They showed no difference in overall survival, disease-free survival, and actually in their local regional recurrence, there was a titchy difference, 10% versus 13%, but that didn't reach statistical significance. But also, very importantly, bottom right, they did not show any benefit for the patients. So the difference in FEV1 was 2%, which is not a clinically important difference. So they didn't show harm, but they did not show benefit. I think that is really important when we come to decide, why can't I do a segmentectomy? Because the question is also, why should you do a segmentectomy? Right. Coming to the 10-year results of JCOG, they did actually present this strangely in an abstract for the AATS. They actually showed that they were losing significance in their 10-year overall survival and disease-free survival, but they actually still concluded on their slides the 10-year survival is 83% versus 80%, although the confidence intervals now cross 1. The disease-free survival, there was 2% sort of 1% difference crosses the confidence interval, so it's not significant anymore. And then they highlighted the doubling of the relapse rate. And they also did highlight it was the death from other diseases which was driving that mortality in the lobectomy. But they didn't really go all the way and say, don't do segmentectomy. Before we go for the mic drop bombshell slide, who is Hisao Asamura? He really is probably the most prominent thoracic surgeon in Japan. He's hugely respected, and I respect him all the more for coming out with these trials. He really is an amazing person, has been vice president of endless things. So, this isn't just some renegade making these slides. This is JCOG. So this is what he says. So the difference in overall survival between lobectomy and segmentectomy has disappeared, so they're equivalent. The significant advantages of segmentectomy cannot be duplicated after at 10 years. There was no difference in recurrence-free survival between the two groups at 10 years. The recurrence of lung cancer is more common in segmentectomy than lobectomy, 71 versus 47. Segmentectomy causes more recurrence than lobectomy. Local regional recurrence is double in segmentectomy than lobectomy, which is clinically and statistically significant. What else do we learn? Well, importantly, there's no difference between the groups in having more respiratory disease if you have a lobectomy, having worse COPD, having more strokes, having worse hearts. So actually, there's, as well as no respiratory benefit in lung function from having a segmentectomy, there's no protection of having better COPD, better cardiovascular disease, less strokes. So there is nothing that they can point to in JCOG that says, don't do a lobectomy because you're protecting people from other things at all. So no difference between lobectomy and segmentectomy for lung cancer death, which shows that segmentectomy is not somehow more oncologically effective. So why were there more deaths in the lobectomy arm? This is directly a slide that Hisao Asamura has put together. The deaths came from other cancers. And he can't explain it. This cannot be explained in any meaningful oncological reasons. It might just be fair to think that this might have happened only by chance, despite that p-value. And the p-value, as Eric will say, might just be a function of it being such a big trial. It doesn't have clinical plausibility. This is his final slide. There is no survival benefit for segmentectomy over lobectomy. It may not be inferior, but it's certainly not superior. There's double the recurrence, and that's important. And there's no benefit, there's no functional reward, either lung function or better COPD or better heart disease or better strokes. There is nothing better about doing a segmentectomy. So the JCOG rule at 10 years is the treatment of choice should be lobectomy. It needs revision of our conclusion at 5 years. Do not do segmentectomy, must do lobectomy. The Lancet paper is misleading. We are sorry for this. So with that, I'll close and move on to the next speaker.
Thank you, Joel. Well, that's a pretty outstanding slide to finish off with. And okay, so we'll move on then in the interest of time to Eric. Thank you, Eric, for coming on and sharing your expertise. We look forward to hearing your view on this.
Great, thank you very much, Karen. So I'm going to provide some statistical background as to what we're witnessing here. Has been known all along. It's not a surprise at all. Here are some of my disclosures. We do sublobar resection to try to reduce the amount of tissue loss from a lobectomy, to improve function, breathing, so on and so forth. But we need to ensure there's no compromise to procedure safety, oncologic safety, and survival. That's kind of like a common sense thing to do. I've been giving this talk for many, many years now, and I've been booed off stage because people just think I'm talking rubbish as always when I'm critiquing the paper. And just going to show you a bit of history as what's happening. So this is the JCOG0802. Joel's very kindly gone through the paper already. No difference in lung function loss because the amount you need to resect for a segment and the amount you resect for a lobe approximately the same. My hypothesis is that when you guys do, I don't do it. When you guys do a single segment, you think, man, I'm so good. I can do one segment, right? But when you do a randomized trial, you realize that most of the lesions are situated between segments, between three segments, between two segments, and the amount you sec therefore has to be the same or no difference from a lobe. Also, the classification between lobe and segment is stupid because middle lobe, lingular segment, you know, it's the same amount of lung function. Left upper division segment, right upper lobectomy. It's semantics. It's bullshit. It's just not. It's artificial. So segment and lobe is an artificial classification. So the reason why I'm not against segmentectomy, I'm just against people not seeing the data. Understand that JCOG themselves, segmentectomy were reported with higher complication rates. And then when I speak to this in Europe, people think I'm saying that. No, I'm not saying that. The Japanese are saying that. That's what they report. Higher, complication rates. How complex segmentectomy is an independent predictor of pulmonary complications. So no, it's not as safe as a lobectomy when they were doing it. The next question is, does it compromise?
Eric, sorry, will everybody please mute for me? Thank you, except for Eric. Otherwise, I'll have to mute all and put you back on, Eric. Thank you. Apologies for that.
The next question is, does it compromise oncologic safety? And the short answer is yes, it does, because the recurrence rate. This is the 2002 paper, 2022 paper, by the way, not the 10-year paper. It already shows that it compromises safety. So the recurrence rates are twice higher in the segmentectomy arm. So you've got higher complications, you've got higher local recurrence rates. Now, does segmentectomy compromise overall survival? No, it doesn't, because there was a 3% survival advantage, which was reported as highly statistically significant. What's interesting is 10 years later, it's still 3%, and now it's not significant. And people are making a decision on a p-value, and that's wrong. You shouldn't be doing that, because a p-value is a function of sample size. So at the start of the study, when you have 1,000 patients, everything is significant. Everything is significant. And at the end of the study, when you have loss to follow-up, and maybe, I don't know, 500, 600, whatever it is, it's no longer, the 3% is no longer significant. But what's more important is that you need to screen if the original study was a spurious variation, because improved survival was not expected at the design stage. When you go through the JCOG actual protocol, you'll find that there are 12 concluding parameters, 11 of which mention lung function X, Y, and Z, and only one which said if overall survival was better, we must conclude segmentectomy is better. That was line number 1. And they snookered themselves into a conclusion which they were forced to then conclude. There's no biological plausibility that reduced lung function would improve your survival because lung function wasn't reduced. There's no oncologic plausibility that segmentectomy provides better protection against lung cancer recurrence because the lung cancer local recurrence was twice higher. But most importantly, the effects were not clinically meaningful. And when you ask what is a clinically meaningful effect, my opinion, your opinion, the patient's opinion, the best is to look at the clinical trialist opinion. When they designed the study, it was designed as a non-inferiority because they already suspected that if you take less lung function out, it may be inferior. So the design of the study is non-inferiority. And what they defined as clinically meaningful was 5%. But the difference was only 3. But because the study was so powerful, that 3% became statistically significant, but not clinically important. And the point here is that the observed deaths in lobectomy were due to the development of secondary cancers. So based on all of this, for me, I concluded quite definitively that this was a spurious variation, a type 1 error. Of course, put your the data to hand. Unfortunately, there was an imbalance, I feel, in the randomization. It's so unlucky that you get 31 patients with secondary cancers in the lobectomy arm versus only 12 in the segmentectomy arm. Secondary cancers, these are not lung cancers. And that's the principal driver of mortality in the lobectomy arm. So people in the lobectomy arm didn't get worse survival because their lung function was compromised, as you might think, or because segmentectomy is a better operation. It was just bad luck that the randomization was unbalanced because all you needed was about 15 more non-lung cancer deaths in the lobectomy arm to drive those results. So put your money where your mouth is. Here's a letter I wrote into the Lancet as soon as the paper was published. And you can see the letter was dated 2022. The letter was not rejected by the Lancet. It was sent to the authors in JCOG0802. And you see that I was really pleased to see Asamura's slide really mirroring the points made in the letter. But when I wrote the letter in the Lancet, the key points was no observable differences in lung cancer-related death, and simply that the question of superior overall survival was data-driven. It's a type 1 error. And now 10 years later, we can confirm it's a type 1 error because a type 1 error occurs when you have no clinically meaningful difference, a highly statistical significant p-value, and a large sample size. What's interesting is that the difference in effect is still the same, 3%. Sample size is smaller, no longer statistical significant. So this is classic type 1 error, something I'm going to use in my statistics course as a beautiful example of something that can be spotted actually 3 years ahead. And so this slide, which Joel kindly put out, actually mirrors what I wrote in the Lancet. I know they've received it and they've read it through personal communication and meetings, and they declined to reply to it. Understand that the overall survival at 10 years, the hazard ratio crossed the line, no effect. What's interesting is that there's also a possibility of 11% worse survival, possibly with segment. And here, recurrence-free survival was worse in the segmentectomy arm, local recurrences, up to the possibility of a 30%, 33% increase in disease recurrence or death. And that's where I will conclude and pass on to the next speaker.
Great, thank you, Eric, for that. So we should have listened to you. Now, to move on from there, that's great. I just want, before we kind of go into discussions, is Ram is going to say a few words next about the dendrite-based new thoracic database for the SCTS. Ram, do you have some slides to share, or would you like to discuss?
No, just a quick update.
Thank you.
It won't be long. Just to say that there is, most of the people on the call will be aware that we are constructing a new database with support of industry, building upwards at the moment. And this is a great example where we potentially, every sector, every disease state has had working groups. We've agreed minimal data sets to go in, and many of the people on the call have been part of this. We will give you an overview, hopefully, and a presentation. I'm going to put this forward at the Thoracic Forum if we're able to get a driver through, and then subsequently at the Society. I'm hopeful that if this will allow us to capture data properly. It's going to be possible only if every unit complies, and we're going to try and get some form of communication from Aman, Karen, and the team to say it is going to be used as a marker. The wording, etc., so to drive the chief executives to make sure that we have a data manager in every unit, which will then allow data completion properly. Some units are already fortunate enough to have them working and in fact completing data for the people, for the units. So we don't have that in a lot of units at the moment. I'll have greater granularity on that by the end of next month. We have an opportunity to put in all the fields we think are necessary at this point to address this particular question. If we think it is a question that needs a national answer, and I think the answer is yes, but we would need extra funding which I think we should use to make sure the data is captured properly, and it might be in the form of a registry-driven study. So we've touched upon that before. A lot of people signed in, and we should probably take it outside this group, set up a small working group with the relevant people, Karen, and that's where we stand at this point in time.
And Ram, just to say, how many variables are currently in the lung cancer section of the thoracic database?
I don't have an exact number to hand, I'm sorry, but we've tried to keep it user-friendly, but we have Leanne, Nate, and obviously all the other people in this group have all been involved. I don't have an exact number to hand. Okay. So it will not have the things right now. If we populated that completely, we would not be able to answer the question between segments and lobes, because it will not have frozen sections, it will not have margins radiologically, it will not have post-op pathology in greater detail. So the margin on the post-op pathology, for example. So we should decide what we want, ask questions potentially, and then set it out at this stage, and we can incorporate it into the database and do it at the very outset. That is a possibility.
Eric, your hand is up there. Thank you.
Thanks, Karen. Just to say that this is not a question that can be answered by registry. If you see that the Americans have done it already, they've done 32,000. The question is not between segment and lobe, it's between segment and wedge, whether or not wedge should be the preferential sublobal resection. When you do a registry study or retrospective of how you match it, invariably you will conclude segmentectomy is better than wedge because in Karen, your message already alluded to it. You wrote a message saying, if it's a high risk, I'll do a wedge. And therefore, what you're going to end up is high risk patients dying and wrongly concluding that segmentectomy is better than wedge.
There's a bias based on case selection and stuff.
Selection bias.
Yeah. Okay. And then the other thing from the database, you've obviously incorporated EPROMs into the database, but we haven't incorporated survival, which obviously is a key factor.
Correct. So which is going to be an additional cost which we have to apply for and get, and that is a key factor which we're keen on getting.
Okay. I'm going to hand over, thank you, to Babu Nadu's here online as well, who is leading on the priority setting partnership that's currently been undertaken by the James Lind Alliance. Babu, are you there online?
Yeah, I'm here.
Great, thank you.
Yeah, and I've posted in the group as well that if the community feels the question of segment, wedge, or lobe is still relevant, it is one of the priorities on the long list on the second survey. So if we want to get something funded through NIHR or one of the funding bodies, then if it is prioritized in the top 10, then of course it stands a much better chance of being funded. So if we do believe as a community this is something that's worth exploring, I really urge you all to complete the survey because that weighting is what will give it the to get it in the top 10, because there's about 50 questions for each of the groups, cancer and non-cancer.
And just to put it into context, the cardiac surgical community did something similar. And how many trials have been funded since then?
About 13.
Okay, right. So there's an opportunity there.
Yeah.
Great, thank you. I'm going to move on to Sasha from St. Bart's, who would be an advocate of segmentectomy, or certainly has proctored surgeons around the country doing it robotically. Do you have anything to say, Sasha? Anything you would like to add?
Yeah, can you hear me?
I can indeed, thank you.
Good. First of all, thank you for Joel and Eric for presenting the data. This is completely new data to me, and it will be completely new data to colleagues at work. We haven't discussed this, so I'm not speaking on behalf of Bart's. Secondly, as a proctor, you don't proctor segments that often. You proctor the start off of someone's learning curve when it comes to robotics. I would say the vast majority of cases is going to be done as a lobe. So I even in the UK, which I think is a much better group of people to proctor, we haven't done that much in the way of proctoring segmentectomies, or I haven't, I should say. I was wondering whether you were going to ask me why I'm doing segmentectomy. You say I am supporting segmentectomy. We did segmentectomy from 2019, so 3 years before the trials even broke through the surface, and we have been doing that now, therefore, for nearly 6.5 years, coming up to 700 segments, mostly complex segments. I think our experience is probably better to talk about rather than my proctoring of other people's experience.
Okay, thank you. when we look at the data initially, I think he never said not to do lobectomies. He said in selected cases to do segmentectomies, would have been my take on it. And with segmentectomies, he very much was an advocate, Hasamura, of doing an anatomical rather than a non-anatomical resection. And so then I'm back to this question that has come up with Eric. Really, is the question from today, should we be looking at wedges versus segments rather than looking at segments versus lobes? And, he would have been very clear in his previous data. And maybe my other issue I have is that, we all work very busy schedules and we are reliant on the reports from radiology or pathology reports or access to frozen section, or there's all of these other moving parts or variables that happen in everyday practice, which has lent to a lot of variability in how we do what is our index case. And I do wonder, will the trial help to answer certain questions? But could the trial also be an opportunity for us to standardize certain aspects of the pathway in managing a patient who's undergoing surgery for lung cancer? Such as, you're getting a report by the radiologist, how is it to be reported on down to, do you want ratios, for example, CTO ratios? The difference between GGOs and subsolids, often you go to an MDT, that's not very clear. You're looking at, the importance of FTV uptake. Are we looking at, biopsies and pathology? What are they looking at? What are they going to say is a high risk versus a medium risk versus a low risk? But in particular, I do wonder the difference between segments and lobectomies is actually the margin. Is it that we're just getting a better margin with lobectomy that we're not getting with a segmentectomy? And certainly, if people are considering segmentectomies, should we at least have access to 3D mapping where you have your zone of safety from a margin point of view, so you can pre-plan appropriately? Because I think some people don't have access to all of these resources, and it lends that we're just trying to, fit a square peg into a round hole because it's just what we have around us, and we're trying to manage with what is available to us. So maybe doing something will help us to standardize and provide guidelines and really put in expectations, not necessarily for the surgeons, but for the people within the trust that have to support the surgeons doing a good job. Would be my take on it. Does anybody any comments to make?
Yeah, I would like to say that the question, in my view, is not so much segment or lobe. If you do sublobar, you get higher recurrence rates. That's kind of all the studies show that, whether it's CLGB, JCOG, or Ginsburg. The issue is that, is it okay to accept a higher recurrence rate? CLGB 7-year recurrence was 13% in sublobar and 10% for lobectomy. And I think that's an acceptable recurrence rate, so to speak. For me, the real question is, if you choose to do segmentectomy, you've already committed yourself to do an operation that has more complications and higher recurrence rate compared to lobe, for example. Now, if you think that the complication rate is higher compared to a lobectomy, think how much more safety you're going to get from a wedge. I'm talking about lesions that can be done by both. I'm not talking about deep-seated with a wedge, you have to force it. I do segments as well, obviously, but for my practice, the choice of segment or wedge is peripheral or central. Simple as that. Then the sublobar, or what you accept for recurrence rate, is about 13% versus 10%. That's kind of my take on the situation. But if everybody moved more to wedge, you're going to get more operations done, and if you can do it as day case, you're going to be able to compete with radiotherapy much better.
Thank you. And we have a hand up from Manchester.
Thank you. Hi, Karen Felice from Manchester.
Thanks, Felice.
I wonder whether there is an indication to do a sublobar resection at all. If we are saying that lung function is not different, if we're saying that 10-year survival is not different, if we're saying that there is no there's a higher rate of complications. The operation is clearly more difficult than doing a lobectomy in certain hands. I wonder whether is there a closure on a non-intentional segmentectomy full stop. In what circumstances would we choose to do a segmentectomy or a sublobar resection versus a lobectomy if there is no advantage in terms of lung function, survival, so on and so forth? When would we do it? And I do understand that a sublobar resection, especially a wedge resection, is a quicker operation, but other than time in theatre, when would we commit to do it? Because if we are saying that someone is not fit for a lobectomy, then it's not fit for a segmentectomy either. If lung function doesn't differ, in a statistical and significance and in a clinical significance. Thank you.
Thank you. Sasha?
Yeah, I think it's really important to not just lump all segmentectomies together. In the same way as Eric is not going to lump all nodules together, he's going to make a differential between peripheral and central. I think we have to accept that the simple versus complex may be one way of looking at it, but the upper versus the lower, we're starting to look at our data for that. We're approaching 700, so we've actually done more than the arm of the study. It's not going to be a randomized controlled trial by definition, but we will be able to get a lot of data out of our 700 patients. We do know that the vast majority of them were complex. In other words, they weren't sixes or lingulars. And just like we had this discussion many years ago about N2 being a heterogeneous group, we can't keep on talking about segmentectomies being a single group. They are a heterogeneous group of segments in the same way as they're a heterogeneous group of patients.
And so, Sasha, what question would you like from the data then, based on that?
Well, I think the database, I don't know if Ram's going to like this, but I think the database has to be very clear what we are taking out. We do need to know whether there's 3D modeling beforehand. And we do need to know that the pathologists are up and armed to give us the right information, to give us margin. So pathological margin versus 3D preoperative margin, bearing in mind we have no way at the moment of intraoperative margin discussion because a fuzzy ICG thing put in by either NavBronch or by ION does not give us margin. It gives us an idea of where something is. And it'll only do for peripherals anyway, but when it gets 2 centimeters deep to the pleural envelope, you're missing the ICG and you have no idea where your margin is. So I would like to have enough data from that database to get enough information out to go down the route of this registration trial.
Okay, thank you. Ram?
Yeah, thanks, Sasha. No, there will be no restriction on what we need to put into the database. We can put as many questions as we want, but it's only going to be as good as what people fill in. So by all means, we can build. We have the ability to add more questions onto the existing stems. And we've definitely not gone, like I was saying earlier, into the granularity that we will need to answer the question as it stands, because we are trying to make it user friendly so most people engage. But certainly with this specific question, although it won't be an RCT, and there will be the usual inherent biases as a result, we can certainly get a big volume database study into it. And then we can modify as needed, potentially. The one question I had for Eric, Joel, and Sasha, who are on screen as I see it, and Karen, yourself, my issue is in terms of how is this now going to define our conversation with the patients? Because if I have a patient who's got a good lung function, sat in an apical trisegment, left apical triseg, 15 millimeter nodule, very amenable to an apical trisegmentectomy, what am I going to tell this patient now on the back of the last slide?
Eric, thank you.
I was mentioning in the chat group, tell them the truth. I tell my patients the truth. You've got two options here. You can either take the lobe out or take the actual tumor itself out. If we take the tumor itself out, there's a higher risk of recurrence. I quote the data from CLGB because I use all comers. It's going to be higher in the local resection arm. Which would you prefer? Some patients in whom they are really concerned about recurrence rates, then we'll do a lobe. And if they want to save the portion of lung, then they will choose a sublobar resection. And as mentioned, sublobar resection, I offer wedge based on peripheral and segment based on depth. And there's a comment that Adrian said trisegment is actually a segment. I think trisegment's a lobe, right? It's an upper lobe.
Joe, thank you.
One thing we heard in the chat that we haven't heard yet is the view that segments do make your breathing better, and that actually it's FEV1 that's the fault of CalGB and JCOG. So I've certainly heard in other forums that we've just measured it all wrong. Certainly before this conference, I'm sure if I held a poll and said, do you think segments make you less short of breath than a lobe, you'd all be going, of course. So my question out to the group, have we just measured the wrong thing? That's certainly what Nasser Al-Talki says. He thinks the reason he only got a 2% benefit is because FEV1's the wrong test, and we should be doing CPETs. Obviously, CPET, we know, isn't brilliant for excluding people for an operation, but maybe you'd preserve better CPET functional ability with a segment than a lobe, and we've just measured the wrong thing.
Yeah, just to follow on, it's me to put some of these comments in. Lung resection is common and debilitating for patients and is an unmet need. And I do feel that this could be a driver for a trial because it is complicated, of course, by the fact that not every bit of lung we remove is equally functioning. So we would need to consider that in the study design. But I think there is, otherwise we'll just be repeating the same type of study that others have done. I think the value is if we can show that this is beneficial from the patient perspective, and then if the recurrence rates and survivals are fairly similar, then we can counsel the patients accordingly.
So, like, my thoughts on it is that, you mentioned the segment versus the wedge, Eric. And yet, when you look at Asimer's data before, he was very much about the peripheral-based lesion. That's when he kind of advocated a segmentectomy above a lobectomy. But now we're kind of changing the location of the lesion, maybe the character of the lesion. Are they supposed to be GTOs or subsolid lesions? And then the size of the lesion. So are we asking a different question based on the character or the location of these nodules and how we should treat them? And I suppose he always focused on nodal sampling and margin clearance, but quite commonly that isn't available to people perioperatively, either because they don't have frozen section available to them or they're trying to get through too many cases on the list. Do you have any thoughts on that, Eric?
Yeah, I think Japanese didn't have wedge at all as a option because they look down on the wedge. I think they think it's like a poor man. You can't do thoracic surgery, you do a wedge, so they would never have the ability to make any inferences. They have earlier other Japanese studies where the CTR is less than 0.5, which is a non-randomized study where they just did a wedge for those type of patients. For me, I'm probably more inclined into Al-Talki's all-comers. If we were to do a trial, I think we should just do an all-comers. The Japanese have gone quite into the CTR less than 0.5, CTR more than 0.5, what to do for each site, so on and so forth. And if you want to then put lobes into it and more granularity, the number of patients you need, it's just not feasible. That's why the trials won't be able to answer questions in that level of detail.
So what's important is that we define, we have very clear standards. We define the assessment process, how we assess the nodule within that particular patient, and obviously the patient themselves, and then we define the procedure. There's a bit about getting standards right here. I think the trial would be very helpful for that. But I'm back to this question: is, are we just going to decide on who needs a segment, or who needs the difference between who should have a wedge versus a segment versus a lobe?
I think if I were to design that study, I would design it the patients 2 centimeters or less. The reason why people use 2 centimeters is important because they define the quality standard. You need a 2 centimeter, the margin of tumor on each side of a wedge. So anything more than 2 centimeters, if it's 3 centimeters, you're going to need 3 centimeters on each side plus 3 centimeters for the lesion. That's 9 centimeter margin. That's essentially a lobe. That's why the 2 centimeter kind of cutoff is used. And I would bring out, you need to get all comers. And what we can do is we can stratify. I think if you are super keen to stratify via CTR, you can just less than half, more than half, and then randomize them into wedge or segment. You're not going to be able to use STAS to stratify, Adrian, because STAS is usually a post-operative diagnosis. Pre-operative, if you only have a needle biopsy, you're not going to be able to accurately assess for STAS. If the study is large enough, we assume that the STAS will be equal in both arms. I think it's an interesting study. I think it's something worth doing, something that we could set up as a wedge is not inferior to segment kind of study and see where we go from there. Because if it's a non-inferiority study, like they both did, we can limit it to about 1,000 patients with a same declaration margin of survival as 5% difference at 5 years. Then the sample size calculations will follow exactly that of JCOG.
Thank you. Adrian?
So there is stuff coming out of Japan at the moment looking at radiographic predictors for STAS. So I think that would be quite useful to incorporate into it. So there are some things that are really quite positive. So multiple ground glass nodules are really quite suggestive of STAS. So I think that it would be worth excluding those.
Okay.
The problem is that you need to ensure that every single radiologist in every single center in the whole country actually uniformly uses that classification, which is acceptable by the rest of the world. And that's why clinical trials, it's a good idea that you suggest, but in practice, it's super, super difficult to actually carry out.
Let's
with
get the
fidelity.
Let's get the radiologist to agree on a reporting strategy, shall we?
I think so. Maybe it will only be certain high volume sites that will do this, but they've managed it in practice.
I can tell you from Mars too, that's impossible. People just can't do that. Not even from
surgeons on this call just thinking, wait a sec, isn't a segment better for your lung function? And so the big problem with these trials is they just haven't shown any benefit with segmentectomy. So if we're all thinking there should be a benefit and there isn't a benefit, maybe the study we need to do is show that benefit. There's been some good comments on the chat of why don't we look at quality of life? Why don't we look at 6-minute walk tests? Why don't we look at CPET? To me, that's the big elephant in the room. We're all desperate to do segments rather than lobes. We don't have any benefit for it. So I just put it out there. The study I would probably see is try and prove a benefit of segment over lobectomy. That's where I'd go.
Sasha?
Question to Eric. How long do you think it will take to get an answer out of this? If we are very concerted, if we work through Babu's network, we get the funding very, very quickly, when can we get an answer? And do you think technology moving on in the meantime will then make that answer pointless or obsolete?
No, so for me, I think the real question of value is wedge versus segment, not from an overall survival point of view. I don't think that's even important. I think from an in-hospital point of view, how long does it take? How many can you do? How soon do they go home? You don't put a drain in, no air leak. How well do they feel? And yeah, QOL, quality of life, Fine, that's great. I think that's where the difference is going to be, wedge versus segment.
There's
But
also a
for
health
the
economic
purposes of
kind of comparison to that as well, isn't there, Eric? You know?
yeah, but for the purpose of overall survival, I think if you repeat the JCOG0802 at 1,000, it's anyone's guess. I don't actually know. I don't actually know. I know we do. Is it how many? Does anybody know how many lung resections we do a year in the whole country? We'll have to divide that number by 10 times to estimate what the 2 centimeter people who are willing to randomize is. Violet took 3 to 4 years to randomize 200 patients, and we have 5 centers. So if we have
500.
25
500
centers,
patients.
500 patients, sorry. So if we had 20 centers, yeah, maybe we could do it in 3 years.
Felice?
Just very quickly to Eric. So if we are comparing segmentectomy with wedge resection, are we therefore saying lobectomy is the standard, and when we can't do it, we therefore decide whether it's a segment or a wedge? Is that what we're saying? Because I still think my question, in essence, has not been answered. So when do we do a segment or a wedge if there is no difference in terms of lung function, unless we demonstrate that there is a difference in some other clinical parameters that have not been looked at yet? You know what I'm trying to say?
Yes, I do. And the answer, I'm kind of slightly hesitant, is because you're all going to laugh at me again, but the whole world has got it wrong. Both Japanese and American, they've just got the whole trial wrong. They looked at the amount of lung function you lost, not the amount you saved. And therefore, they got the answers upside down. It's a big statement to make right now, but I'm trying to get the data and then I'll show it to you. So a simple example. 2 centimeter lesion in the lingula, you do a wedge, you lose 5%, but you've saved 20 because you left the upper lobe alone. I'm not sure that makes sense, but basically everyone's got it wrong. So they don't count the amount you saved, they just count the amount you took out, which defeats the purpose. That's why both studies are wrong. I think Joel gets it, you're nodding your head.
It makes a lot of sense, doesn't it? Yeah. Just
I
you
kept that a
saved
big
a whole
secret
upper lobe
for a long time.
tri-segment. Yeah. Versus, I mean, it's a great point. Versus doing a posterior right upper lobe segmentectomy, you save the anterior and apical, and that's 7%. Yeah, it's a very, very good argument.
And
So
Sasha?
yes, we should do sublobar.
Mm-hmm.
Yeah, but going on with what Eric's just said, I think it's really important, the quality of the segmentectomy. If you do a segmentectomy but you ruin the rest of the lobe, then it's been pointless. And this is something we're looking at with our large data set at the moment. We're trying to work out. We presented at SRS our 910s, which are arguably the most difficult segments. They're bloody awkward in theatre, and there's often a CT that follows because you're worried about what the lobe looks like. And the question is, have you ruined that patient's rest of lobe? And that's, to get that sort of information out, you need spec perfusion before and after, to understand what real lobar loss of function you've got.
Just struggling to get in my head who the inclusion criteria would be for a wedge versus segment trial. Would this be like sub 1 centimeter, no histology, tiny little splodge that we just want to know what the answer is? Because obviously if it's 1.5 centimeters, they need a lobe. So what's the inclusion criteria? Who goes in this trial and who doesn't?
2 centimeter lesion, known as suspected lung cancer, where you can do both.
But you can do lobe as well. And
segment or wedge,
JCOG says you should be doing lobe.
No, the world's got it wrong. That's why. They got it wrong twice, man. So the first part, the world understands what I'm saying now. But the second part, you guys will understand it with time. But basically, I think the question is sublobar, wedge versus segment. Forget lobe. But if the patient wants the ultimate lowest recurrence, then that's a lobe. And also, increasingly, like what Karen has said as well, It's the margin, because you know the Copenhagen study that Renee just put out, right? That makes a lot of sense, you see. The study that Renee puts out, tens of thousands of patients, is that the wider the margin, the less the recurrence rate on a wedge. Same applies to segment, same applies to lobe. The ultimate margin is a lobe. That's why the recurrence rate is less, in my view.
How would you randomize somebody less than 2 centimeters segment or wedge when you've got a JCOG trial saying you're going to double your recurrence and there's no benefit to you in joining this trial? Just have a lobe.
Because we would say that the CALGB says that the recurrence rates are broadly comparable, and we don't know which is the best to use because they never randomized to it.
Felice?
So are we then saying that probably the most important parameter to look at is the free margin from tumor rather than the operation itself? Because that would make more sense to me, which is ultimately what I wanted to come to. Should we compare based on, you know, how much margin we're going to give? Because if we can't achieve a good margin with a wedge or a segment, then there's no point to even consider it, isn't it?
That's my personal hypothesis. Yeah.
Yeah.
Yeah, and I would resonate with that. I think for me, from a logical point of view, it makes a lot more sense to look at free tumor margins rather than anything else, and then alongside, you know, clinical parameters, as you said.
When things cross a fissure, for example, they behave more like a T3 lesion anyway, don't they? You know, but there's a little bit about understanding the margin on the other side. You know, taking the lobe out with a little bit of a wedge may not actually be sufficient. Ram there, thank you.
Yeah. So I think Joel's probably asked the question. I think when you're trying to recruit into what you're suggesting, it's important we state the recurrence rates being higher, and then if the patients want something with a lower recurrence rate, then obviously that cohort is not going to come in to this suggested pattern. But we have to have the evidence. How would you suggest to them that having less lung, you're going to quote the CALGB to state that the recurrence rates are comparable? Where are you going to give them the advantage in lung function / quality of life? What would you use to have that pre-trial randomization discussion?
So quality of life will be measured. There's equipoise, as we don't know which is better. Lung function will be measured before and after surgery, and only at one point, because the lung function never did change between 6 and 12 months in the other studies. So if you measure just once, maybe at 6 months, say, to compare the lung function, how much lung function is lost, with the anticipation that it should broadly be the same wedge and segment. I don't think that will be the primary question. For me, the primary question, well, for the NIHR, the primary question is overall survival. For me, the primary question is how much better can you get them out of hospital, how much quicker, and how much, you know, shorter would the operation take? I.e., the wedge has benefits, and we need to demonstrate that there's no impediment to, say, overall survival, recurrence-free survival, local recurrence, compared to a segment. And that question has not been answered yet.
But Eric, if we go back to the basics, if this is a peripheral lesion, then we're looking to see whether a wedge is this inferior, superior, whatever, to an anatomical segmentectomy, where you're doing your lymph nodes and checking obviously margins in both categories. But there is a bit about, you know, giving people the knowledge beforehand, you know, for example, as you said, with segments, you have to make sure the lesion isn't crossing 2 segments, etc. So that's probably one question. But if the nodule is deeper, you know, then we're saying that these people should just have a lobectomy.
Or segmentectomy, yeah.
But then we're going back to the segmentectomy versus lobectomy
but they won't,
question.
So the trial is segment or wedge. So if it's deep, you can't have a wedge. If
You
it's too
can't do
deep
a
for a
wedge.
wedge, you can't do a
Exactly.
wedge.
So
So
these are
you
only
wouldn't
peripheral
include.
lesions that
Yeah,
are
so
either
it'd
a
be a
segment or a
segment
wedge.
or lobe, but not
But if
within the study.
But if they're a deep lesion, then we're
Don't
saying
recruit.
we're not recruiting, but we're actually, as a, you know, we have to kind of probably issue a statement from SCTS. Are we saying people are going back to doing lobectomies?
I don't think the SCTS needs to make a statement. This is about clinical trial inclusion. well, we're talking about the possibility of a national study, right? Wedge and segment. So we'll just put it as a patient information leaflet.
Doug, thank you.
Yeah, thanks. I would agree with you. I think on the basis of what's been presented here, when you're recruiting for a new trial, we're going to have to tell people that your local recurrence rate is getting on twice, twice that if you don't have a lobe, and so there will be a reduction in the overall number of people who would be eligible for this trial. I just wanted to put some numbers in about how much of this work gets done in the UK to think about how hard it would be to power. So for lung cancer in the English NHS last year, there were 6,090 lobes for lung cancer. For non-small cell, 2,195 segments and 397 wedges. So whichever proportion of that are peripheral and would accept the higher local regional recurrence rates are potentially open to your trial.
How many segments, sorry, Doug?
2,195 in 12 months.
Everyone is doing segments. See, that's the problem with the country.
How many wedges, Doug?
397 wedges for non-small cell lung cancer, 12 months in English. 397 wedges, 2,195 segments, 6,095 lobes.
Irrespective of patient comorbidity.
That's just all comers in the English NHS for non-small cell lung cancer.
Okay.
I think it looks good. If you recruit, I don't know, a third of that, it'll take a few years and we should be able to get 1,000.
Felice?
So if we're saying this, if we're looking at peripheral nodule, then should we then reduce the size of the nodule that we are into the inclusion criteria? Would it be a reasonable thing to say? I.e., if it is 2 centimeters, we do a lobe, but if it is 1 centimeter and is peripheral, then we compare wedges versus segment. Is that a reasonable thing to say? Or do we stick to 2 centimeters?
Yeah, because CALGB already did it. 2 centimeters, there's no difference in outcomes between segment or wedge.
So less than 2 centimeters. And what about the difference between GGO and subsolid, Eric? Sorry.
We would have to stratify it. As in, everybody just comes in, all comers. When we stratify, what we mean is that if you as a surgeon operated on 3 GGOs, 3 part solids and 3 solids, because of the randomization by the tumor tumor consolidation ratio, you'd have operated equal amounts in each arm, segment and wedge.
Yeah, so sorry to barge in. We have then to say that when we talk about the dimensions and centimeters, we talk about the solid component exclusively, So we say solid component less than 2 centimeters rather than total size.
So the CTR covers both. It's the consolidation to tumor ratio. So the consolidation is the solid component, and the tumor is the solid plus part solid, plus the non-solid component.
That's not what I meant about standardizing CT reporting and stuff when you're trying to work out what to do with people. Joe?
Yeah, we're just getting to an hour of our discussions, and I just wanted to make the point that there are 70 people on this call. Most of them are jobbing thoracic surgeons, and the main thrust of this call is to give out the message that JCOG is telling us we're doing lobectomies, not segmentectomies, because of less recurrence and no benefit to the patient. So I think we do just have to say loud and clear that we are talking now a little bit about a trial to try and nuance things, but actually right now today you're talking about new standards in the UK. Our new standard is a lobectomy for people with good lung function and proper lung cancer. CT ratio more than 1/2, so there's more solid than, and most of our tumours are solid anyway. So, I don't want people to come away going, oh, they were all saying that wedge and segments are fine. Actually, again, they're not. This study says there's no evidence for benefit of segmentectomy. And so your only exceptions are some exceptions we talked about right at the start, tiny little weeny things that you don't even know it's cancer. So let's find out what it is. But your standard lung cancer should be removed by a lobe unless you've got a really good reason not to do a lobe, or it's a metastasis, so totally games off, or you have such terrible lung function. But again, we've discussed there's no benefit in lung function. So I like your idea, Karen, of an SCTS statement of the default situation for tumours in the UK as a lobectomy, unless you're not going to tolerate it in some way.
Samura has said, the data clearly states there's no difference in outcome. It doesn't state we must do lobectomy. Whether you do lobectomy is up to you and the patient to decide.
So there's no difference
But
in
the
outcome.
decision, yeah, but there's no
Because
benefit to a patient either.
No,
There's
exactly.
no benefit and only risk.
So if there's no difference,
the balance is lobectomy.
Why?
So exactly as you said, you have to tell your patient, I am risking a doubling in your chance of recurrence, local recurrence, and I cannot give you better lung function or better outcomes. So I can't offer you better outcomes. I can only offer you inferior outcomes. I can't tell you anything that's better about segment than lobe.
Yeah, and that's where the math is important. So everything you say is correct, and how do patients understand and interpret that? And the reason why I'm very confident is because I actually had this conversation with all my patients, and I can tell you 99% will choose sublobar. 99% of my patients actively choose sublobar because they believe in preserving lung function more than recurrence rates. That's my cohort of patients. And so I would say, or I would put it's important to give the message in a neutral mathematical statement, which is something that patients can understand. So I don't think we should say, for example, the hazard ratio according to CLGB is 1.3 for recurrence rate. We should say if you have less than a lobe, the risk of recurrence at 7 years is 13% compared to 10%. Tell them the actual numbers. Let them decide. We shouldn't make a statement.
Years.
Yeah, 7 years. And the Japanese studies, for example, the recurrence-free survival, the absolute difference was minus 1.3%. That's nothing. Right? Yes,
so in
you're
studies
right.
of
It's
the UK
double. It's double, but the relative difference is huge. It's massive, but the absolute difference is tiny. And so when we speak to patients, we need to articulate in a way they can understand. So yes, by all means, put a statement, but craft it very nicely so that I believe that these studies say that we should talk to our patients better on a more empiric numerical basis.
But Eric, what we're saying is there's no difference in outcome between segmentectomy and lobectomy.
No,
but although there's a higher recurrence rate, 13 versus 10% at 7 years, and that's
we need to get the studies correct, but
yeah,
we should summarize as a patient-friendly leaflet like. Would you choose a lobe or less than a lobe? Here's what happens if you choose a lobe, X, Y, and Z, less than a lobe, A, B, C, and then let them decide. Don't let Asamura decide what we're going to do as a country.
Are you happy to template a patient-friendly leaflet for us?
Yeah, something like that. A doctor and patient-friendly leaflet, so they can understand.
But just in the same way that. So it's important, just in the same way that 72% of the UK population believe that aliens exist without any evidence whatsoever, believing that your lung function will get better with a segment without any evidence whatsoever cannot be supported. We have no evidence that your lung function is better with a segment than a lobe. In fact, we have 2 studies showing there is no benefit. So just because your patient believes their lungs will get better, that's a lie. Whereas we know for a fact there's more recurrence.
So we tell them that there's no difference in amount of lung lost.
So why would they have the operation?
Because patients are sensible and believe in the amount of lungs saved.
But you're talking a segment versus a lobe, Eric. Are you talking a sublobar, which could be a segment or a wedge versus
Karen,
a lobe?
You are a patient. You come to me. You have a 2-centimeter lesion in your lingula. I tell you, Professor Redmond, we can offer you a lobe. We'll take your left upper lobe out, and that's about 25% of lung function loss. Or we can take a section of the tip of your left lung, approximately 5% of lung function loss. Randomized trials suggest that if you take 2 cohorts of the same size, and you by chance allocate them to either operation, approximately speaking, the amount of lung loss will be the same. But you, Karen, are a patient, and you are going to receive either 5% or 25? What are you going to choose? What would you choose?
It's the way you're phrasing it, though, Eric. I'd choose 5%.
No, I'm phrasing it absolutely neutrally. I'm not. It's the truth.
Sure.
You have a 2 centimeter lesion lingula. How much you lose? A low versus a pro edge. You tell me. I don't know. I don't say I'm biased.
Ed,
Edward's got
you're
his
there.
hand up. Yeah.
Thank you.
So Eric, I think it's a really interesting way of phrasing it, right? You're focusing on one aspect of this, but you're missing another. I think the fact that a group of 70 or whatever Joel said people have managed to argue about this and still have differing opinions for an hour means that in a 20-minute consultation, trying to explain this objectively to a patient, no matter how you put the maths, is challenging for most of us. And the other thing I would say that might be a bit controversial is patient cohorts are probably quite different across the country. So our communication is different, but also our patient groups are different. So, I mean, the numbers are the numbers, there's no doubt about it, but actually we know that people don't understand numbers.
Doug, thank you.
Hi, thanks. Just as a STS thought, I just would caution that in an English context, the people who should be issuing guidance is NICE. They've got the ability and the resource to meta-analyze this data in line with other data, look at the resource implications and the health economics, and issue a fully thought out guideline. I think there's maybe a role for SCTS in making sure people are aware of the recent publication and the recent new discussion from Professor Asamura. I'm just not sure we've got the resources to issue a guideline.
But the statement could be that we've asked NICE to issue guidance on this following the recent publication. Would be reasonable, wouldn't it?
I think that would be great. That's my personal opinion.
Thank you. Ram?
I think that's a very sensible approach. I completely agree. I just wanted to say that if we highlight what's come in and put it out on the SCTS badge with people signed in and point them to the links, and then if we can get a summary statement rather than a get to the patient-friendly leaflet stage, as and when there is a guidance that comes through, we get a summary statement summarizing the headlines, then that would be a 2-page thing that we could send out. I think that would be a sensible way to do it, rather than saying, or we may well come to what Joel said or what Eric said. We may come to that, but we are not there quite yet, I think. So we do need to ensure conversations convey recurrence and possible saving or improvement of lung function, as they've highlighted. So it's something to be done as a group, I think.
So there should be a summary of the statement of fact, and that we could give that to our members, but at the same time ask NICE to issue some guidance on this for us as a group. And then at the second stage of it is consider a separate working group to basically put together maybe a randomized control trial, something linked maybe to the registry, or maybe to the priority setting partnership through the JLA that we can look at one or two of these questions. And the one that seems to come out the most is not about lung function between segment and lobe, but more so about segment versus wedge in peripherally accessible small nodules less than 2 centimeters.
Quick question to Doug. Will NICE actually be interested, since there's no cost implication to any of this?
That's a really good question. I didn't put my hand up again. I mean, there is a mechanism for us notifying them of new data. In fact, I did it for the Segmentectomy trial when it came out. But you're absolutely right. The NICE process is glacial, isn't it? They haven't said anything about this excitement of segmentectomies, and now it's over. They've missed their chance. So I do think we should do that. That is the process. I guess maybe I should rephrase what I earlier said and said I think SCTS is not probably the organisation to be issuing guidelines like this, but I accept your criticism of NICE.
Yeah, by all means, tick the box, but I don't think that's ever going to happen. So let's just, do the other two as well.
Just one thought. Having done the health economics with NICE before, actually recurrence is more expensive to health economists than you think, because it generates an awful lot of new trips to hospital and new biopsies and things. So I wonder, actually, if you've got double the local recurrence at 10 years, I suspect there actually is quite a cost involved in that. But I'm just guessing. I don't know.
No, man, because the recurrence-free survival, the absolute difference is 1.3%. I calculated it. It's nothing. There's no difference. It's numeric. And so, again, let me give you another example of numeric. why. Let me explain to you why 5% was a minimum difference, but 3% is statistically significant, because the hazard ratio 0.86 for the reduction in OS, if you reverse it round, it translates to a 3% improvement in survival, because the numbers are 90% and 10. So the bottom line is absolute and relative. We need to know both. So the relatives always sound horrendous, and the absolutes are actually very small.
Yeah, I totally take your comment. I would say when we in the last lot of the NICE guidance, when there's that recommendation for trimodality therapy, which, as everyone knows, did not have a survival benefit, there was just that suggestion that it was going one way. From memory, the costs that NICE put on recurrent lung cancer is about £7,000 or £8,000 per patient. But yeah, I don't know. Wait and see.
From CLGB, we expect it to be the same in both arms.
Okay, so with that note, it's now 8:20. Thank you for staying online, everyone. Thank you for your time. And so really that's the objectives from this. I think we've had a good discussion. So I kind of outlined what we'll do from here, and we will keep members notified as well. We'll send out some notes in the newsletter. What do you think, Doug?
Yeah, I would just say thanks to Joel and everyone. This has been a great way of letting everyone know very quickly about a change in evidence, and I think SCTS should be doing our best to to increase the spread of this, so everyone is aware, as the people here are aware of what's happening.
Okay, great, thank you. I'll be in touch with some of the key players today around setting up a working group. All right, take care. Bye bye.